Good afternoon and welcome to today's webinar, Optimizing Acute Stroke Care. My name is Eleni Anzelatis and I am from the Community Health and Wellness Department at Suburban Hospital. In honor of Stroke Awareness Month, we have assembled our multidisciplinary stroke team who will be discussing the risk factors, signs and symptoms of a stroke, what to do if you think you or a loved one might be having a stroke, and the care that you will receive at Suburban Hospital. Today's panelists include Dr. Malik Adil, Medical Director of the Stroke Program at Suburban Hospital, Dr. Ab Srinivas, Interventional Radiologist at Suburban Hospital, Dr. Edward Healy, Chairman of Cardiology at Suburban Hospital and Cardiologist at Johns Hopkins Community Physicians Heart Care, and Victoria May, Stroke Program Manager at Suburban Hospital. Before we begin today's presentation, I just want to go over a few housekeeping items. First, this webinar is being recorded and will be made available in the coming days. Secondly, we hope that today's presentation will be informative. If you do have a question, please use the Q&A feature on the bottom of your screen, and we'll be answering questions at the end of the presentation. Lastly, and most importantly, when the session ends, there will be a screen that will appear to complete the evaluation. Please take a few minutes to complete this evaluation as it helps us with future programming. Thank you again for being here. Thank you to our wonderful panel for being here as well. And we will get started with Dr. Malik Adil. Thank you. Dr. Adil, I don't think your sound.
I'm sorry. Okay, so good afternoon, everyone. First of all, thank you so much for joining. This is a great turnaround. I promise we're going to make it very, very informative and short and give you a maximum time to ask questions. So before jumping onto the stroke symptoms, I wanted to quickly tell you about the different types of stroke. So we have two different types of stroke. One is a ischemic stroke and other is a hemorrhagic stroke. So the ischemic stroke is when there is a blockage of the vessel and the area of the brain is not getting enough oxygen or blood and the cell dies over there. This is ischemic stroke. The hemorrhagic stroke is when there is a rupture of the vessel and the blood accumulates itself in the brain. So the differentiation between these two strokes are important because the treatment is different. Moving forward, I wanted to talk about a little bit the risk factors of stroke. I'm not going to go too much into detail, but there are common risk factors like hypertension, high blood pressure, diabetes, high glucose, hyperlipidemia, which is high cholesterol, obesity, sedentary lifestyle, not doing appropriate exercise, and eating a healthy diet. All these are the risk factors. But remember that all these risk factors does not cause a stroke all of a sudden within few days. It takes many years, 20 years, 30 years, or 40 years to develop some changes in the brain and then causes a stroke. So this is just a brief introduction of the two different types of stroke and some of the risk factors. Now, next slide. So this is a very important slide, stroke symptoms. What I say to my patients is that these are the protective symptoms, because if you don't have symptoms, you're not going to seek an attention, right? You're not gonna know what's going on. So we as a stroke neurologist develop a small score called FAST, which you all might aware of. F is for face, if there is any facial weakness, A is for arm weakness, S is for speech, and T is for time, that as soon as you see these symptoms, call 911. This score is very sensitive. 60 to 70% of stroke patients present with these symptoms. But these are not the only stroke symptoms. There are many other stroke symptoms that one can present. And if you look at in this chart, the symptoms a loved one may experience or you may notice yourself. Now, this can be a confusion or difficulty in understanding. Sometimes people think that the patient is confused, but actually the problem is not understanding or trouble finding words. This is a very common stroke symptom when the stroke is happening in the language area. Similarly, dizziness. Now, the dizziness can be because of many other things, right? It can be because of an ear problem. It can be just because of headache. But dizziness is a very common symptom when somebody is suffering a stroke in the back of the brain. At the same time, if someone is suffering a stroke in the back of the brain, loss of balance can also be a presenting symptom. Numbness, severe headache. So severe headache is very, very common in bleeding when there is a rupture of the vessel. But in 20% of patients, it can present in ischemic stroke patients also. Now, again, it's a very non-specific symptom. A severe headache can be because of the migraine, it can be because of any other thing. But stroke headache is very different compared to any other cause of headache. Like it's usually a very severe headache. The other is trouble finding words and trouble walking, vision changes, weakness. Now the take home message from this slide is early recognition is the key. It's very important to recognize stroke symptoms early and call 911 because time is brain. Faster you come to the ED, we can do a much. So stroke symptoms, take home messages, early recognition is the key. Next slide. Okay, I'm gonna hand over to Victoria.
Sorry about that. Okay, so as Dr. Adil said, time is brain, because they say that 1.9 million neurons are lost for every minute that a stroke goes untreated. So as soon as you recognize stroke symptoms in yourself or someone you're with, we strongly encourage you to call 911. Don't attempt to drive yourself or drive the person experiencing a stroke to the hospital. As we say, don't stroke and drive. What we want you to do is call EMS, and because they're going to be able to activate the emergency room to let us know that they have a potential patient with a potential stroke coming in, so that we can start getting all of our resources ready and prepared to meet you once you come to the emergency room. When EMS arrives, there are some critical pieces of information that it's important that you be able to tell them to the best of your knowledge. The first one is, when was the last time the patient was seen normal? When did you see them without having expressing or having any of the symptoms that Dr. Adil described? When did you first notice the symptoms? This is critical to help us age when the stroke occurred and to help us be able to determine treatment eligibility for a patient. Does the patient take any anticoagulants? Specifically Eliquis, Plavix, Xarelto, Coumadin, any kind of heparin, and when was the last dose if they've taken it? Because again, this can impact our treatment possibilities for a patient if they are in fact having an acute stroke. Does the patient have any drug allergies? The big one we're looking for is any kind of allergy to radiologic contrast. Or do they have any shellfish allergies, which can be a cross allergen? Does the patient have any metal or implantable devices in their body, such as a pacemaker, an AICD, an infusion pump, or a neurostimulator that may make them ineligible to receive an MRI? It's very important that we know that. If we can't get that information, we will certainly do screening x-rays to evaluate for those things. But if we can not have to do the x-rays and get them quicker to MRI, that's better for everyone. And also contact information for someone who either witnessed what was going on or can make medical decisions for the patient. It's particularly important at this time with COVID, visitor restrictions, that the physicians be able to have somebody that they can call to find out and get more information about the patient and what exactly occurred.
Victoria, could I add one thing there?
Sure.
It's Edward Healy from cardiology. I just want to point out that most of the pacemakers and defibrillators or ICDs that have been implanted in the last 5 years are labeled as MRI safe by the FDA. So although we still need to know that information, because even if they're labeled as safe, there are some steps we need to take. Having a pacemaker or an ICD does not necessarily mean that somebody can't get an MRI.
Thank you, Dr. Haley. Okay, Dr. Adil.
So thank you, Victoria and Dr. Haley. You made my job easy. Okay, so in ED, So you all did a wonderful job recognizing a symptom and bring your loved one to the ED. Now it's our job. So as Victoria was mentioning, that timing is very important. What is the last known normal? What is the symptom discovery? These are the timings that we really need to make a decision. What is the appropriate management? What is the appropriate treatment for this patient? So that's the information that ED is going to collect. And then as Dr. Haley was saying, the metal screening. I mean, a lot of metals are compatible now, pacemaker, but there are many metals that are not compatible. So then we cannot do MRI on those patients and we have to take for a CT scan. In addition to that, for these imaging and treatment, we have to prepare these patients. So for example, the blood pressure is very high or if the blood pressure is very low, we have to control that. And many other assessment neuroexamination if the symptoms are getting worse or if the symptoms are getting better. So in ED, actually, we're preparing patient to take for imaging and prepare for the next step if this patient is eligible for treatment. So this is what we do in ED. Next slide. Okay, so next imaging, I'm going to spend a little bit time and tell like why CT, why MRI. So as I said that it's in the beginning, there are two types of stroke. One is ischemic stroke, one is hemorrhagic stroke. So imaging is very important to differentiate whether it's a ischemic stroke, which is because of the blockage of the vessel, or if it's a hemorrhagic stroke because of the rupture of the vessel. Because as I said, the treatment is different. So if you do CT, you can do CT within few minutes, and they are very simple. It's easy to read. You just look for a bleeding, and if there is no bleeding, you just treat those patients, and you can look for the clot. The advantage of MRI is there are like 25 to 30% of patients when present to ED, the last known normal or the symptom onset, when the symptom starts, we don't know. So these are the patients nobody is going to treat because we don't know the timing when the symptoms start. The beauty of MRI is that you can age stroke by doing MRI. It takes a little bit more time compared to CT. It takes like 10 to 12 minutes and it gives you a different sequences. And looking at those sequences, a stroke neurologist can tell that what is the timing when the stroke starts and if we can treat those patients or not. So let me tell you this, that Suburban Hospital is the only hospital in the entire state of Maryland who's MRI first. There are a couple of more hospitals in the entire country. So we are lucky to have MRI first because of the collaboration with NIH. So just to recap this, that Suburban has a capability of treating patients where we do not have enough information, what is the last known normal or when the symptom started. We can look at the sequences and we can age the stroke. In addition to that, we can look at the size of the stroke and we can look at what possible cause of the stroke. One last thing, with CT, sometime it takes like 3 hours or 4 hours to stroke to show up on CT. On MRI, you see stroke within 5 minutes. So what you treat what you see. So it's very, very sensitive and specific that we have this luxury at Suburban Hospital. Next slide, please. Okay, so next step is after you recognize the symptom, you bring your loved one, you call 911, you bring your patients to the ED, we prepare this patient in the ED, we have an imaging, and now we know that this patient has a ischemic stroke, and then now it's the time to treat this patient. Now there are two different types of treatment. I will talk about the TPA, and Dr. Silvernas talk about thrombectomy. So TPA is a clot buster medication which you give as an IV form. And what it simply does is basically dissolve a clot. But again, time is brain, time is important. Anyone who presents within 4.5 hour window and has no other contraindication, as Victoria was mentioning, like this patient is not on any blood thinners, no active bleeding, then you can push this TPA within 4.5 hours, and then you can treat. With wake-up strokes, again, as I said, with MRI, if we think that this patient is within 4.5 hours after looking at MRI, those patients can get TPA also. And after pushing TPA, these patients go to ICU. We will talk about the post-treatment care in detail. I will let Dr. Srivanas talk about thrombectomy from here.
Hi there. So my name is Ab Srinivas, interventional radiology. So one of the, in addition to the ability to do MRI quickly here at Suburban, one of the other advantages we have here is that we are able to do thrombectomy, which is a procedure that I'm going to talk about. So within the two types of strokes that Dr. Adil just broke down, the two types are ischemic and hemorrhagic, ischemic being a blood clot. Sometimes those clots are in small blood vessels, and sometimes those clots are in large blood vessels. And as you can imagine, if you have a clot in a larger blood vessel, it's feeding a larger territory of brain, and that stroke can be much more detrimental. And in addition, a larger blood vessel can be theoretically treated with endovascular thrombectomy, and that's sort of where we in interventional radiology come in. And so based on the initial imaging, whether it's CT or MRI, we can figure out whether the clot, if first of all, it is an ischemic stroke, and whether there is a level of clot in a large enough blood vessel that we can remove it to improve the outcome. And so the way that procedure is done, it's a minimally invasive procedure where we make a small puncture in an artery in the leg, and then we feed a catheter, which is a small tube just a few millimeters in diameter, and we thread that catheter all the way up using an X-ray camera into the arteries of the neck, and then eventually into the arteries of the brain. And then we figure out exactly where the clot is. You're doing angiograms, which is injecting some dye through that catheter. And then we have a number of tools that we use through the catheter to help remove the clot, either mechanically removing it or with some kind of suction device, usually a combination of the two. And then ideally get rid of all of the clot in the brain and re-perfuse or reintroduce flow to that part of the brain to help improve the outcome of that stroke. After we're finished, the little puncture is closed with a device that helps heal the artery in about an hour. And usually this is all done in our interventional radiology suite. We use anesthesia, so the patient is put to sleep and then woken up afterwards. In terms of recovery from this kind of procedure, I mean, the main recovery is really the stroke, not so much the procedure itself. The incision, like I said, is a pinhole and is basically sealed up within an hour. So that's the procedure in a nutshell. And I'm sure there'll be questions about that. Maybe later I can get into more and more details about it. I have an example, kind of, this is when people say catheters, they think of all sorts of things, but for us in interventional radiology, it's maybe difficult to see on the camera, but this is a typical size of a catheter that we feed into a blood vessel. And while this is not the exact type of device that we use for stroke, this is very similar. When I say we have mechanical ways of removing the clot, what we do is we have a catheter like this, and through that we feed some kind of stent or other device that helps trap the clot. And this is one that isn't using the brain, but it's very, very similar. And if you can see this stent that I've pushed out, it's basically exactly what we do in the brain with just a different type of device. And then eventually that gets pulled in along with suction, and the idea is to get the clot out of that blood vessel. And go to the next slide.
Thank you, Dr. Srinivas. Okay, so if you do have, or your loved one is experiencing an ischemic stroke, and we do treat it with TPA and or thrombectomy, they will be going to our intensive care unit. In the intensive care unit, their care will be managed by an intensivist who's a specialist in critical care in collaboration with the stroke neurologist. In the intensive care unit, they'll have very frequent vital signs and neurologic assessments. Initially after the procedure, as often as every 15 minutes. And as time progresses, the frequency of the assessments will get longer to 30 minutes, then to an hour for at least the first 24 hours. They'll also be undergoing continuous cardiac monitoring for reasons that Dr. Healy will discuss in a minute. And they will be on strict bed rest, partly because, especially if they have a thrombectomy, they have the groin puncture site that we want to keep from moving so that the artery has time to heal. They're going to have the head of bed flat as well to maximize the blood flow to the brain so that we can try and make sure and save any brain cells that were just sort of stunned by lack of oxygen, and that we can make sure that we recover them. And we're going to be monitoring you for signs and symptoms of worsening neurologic condition. So if something were to happen, are you experiencing another stroke? Or we're also looking to see how you're doing and you're getting better, that the treatment worked. And we're just making sure that there are no signs and symptoms of bleeding, because TPA, one of the risks is that it's definitely an increased bleeding risk for the first 24 hours after administration. If the patient isn't eligible for emergent TPA or emergent thrombectomy, and they're otherwise hemodynamically and respiratory stable, they'll be going to our progressive care unit, which is sort of a step down from our intensive care level, but not quite a typical medical surgical bed. In the progressive care unit, their care will also be managed by an intensivist who's specialist in critical care in collaboration with the stroke neurologist. And they'll have frequent vital signs and neurologic assessments, but not as frequently as they would have gotten in the ICU, maybe every 2 to 4 hours in the PCU. And they'll also have continuous cardiac monitoring. That is critical for stroke patients to help try and diagnose what may have caused the stroke. Okay, so now I'm going to turn it over to Dr. Adil and Dr. Healy to talk about sort of discovering why you may have had a stroke.
Okay. Thanks. I really like this slide because it nicely demonstrates the connection between stroke and cardiovascular disease. And I like to think of stroke as being not only or solely a neurological problem, but often being both neurological and cardiovascular. So if we look at the things on this slide, I think we'll see very easily that a lot of the risk factors for stroke are the same risk factors we think about for heart attack and other cardiovascular diseases. So vital signs to detect high blood pressure, incredibly important. High blood pressure is probably the largest cardiovascular risk factor for stroke. It's very common in the population. We know that it's underdiagnosed and undertreated, and so it's not unusual for somebody to have uncontrolled hypertension and coming in with a stroke, and we want to get that high blood pressure under control in order to prevent future strokes. Same things with high cholesterol and diabetes, both of which are significant cardiovascular risk factors and also risk factors for stroke. And again, it's not uncommon for these to be diagnosed in a patient who comes in with a stroke, and they'll say they were never told that before, or they hadn't given treatment, or they hadn't taken the treatment. So these are things that are really important for us to look at while the patient is in the hospital. Also very important is cardiac monitoring. Another major cardiovascular risk factor for stroke is atrial fibrillation. Atrial fibrillation is incredibly prevalent in the older population. If you look at patients who are over the age of 80, perhaps 1 in 4 of them are going to have atrial fibrillation. So we're going to monitor patients when they're in the hospital to look for atrial fibrillation. And oftentimes we'll do something to monitor them after they've been discharged. It might be a wearable monitor that they can wear for 2 to 4 weeks. It might be an implantable monitor that can last for 3 years or more. But it's important that we look for atrial fibrillation in the hospital and then look for it again after the patients have been discharged. An ultrasound or echocardiogram is also very important because there are certain structural heart problems that can cause a stroke or lead to a stroke. Some of these are in the heart, some of them are in the aorta, which we can also visualize with an echocardiogram. People who have significant cardiomyopathy or a weakened heart muscle can be more prone to have strokes, and sometimes we need to take some special interventions in those cases to try and reduce them. And then we also look at the carotid arteries, which come off the aorta. and disease in the carotid arteries is an important risk factor for stroke and something that we have good treatments for.
Dr. Adil, do you have anything you want to add?
Great, Dr. Haley. Thank you so much. No, I think Dr. Haley covered everything. Just one thing that we are basically doing all this workup again because there are different causes of stroke, and then based on that cause, the treatment is different. So it's very important to do this workup. Now, the workup that you're seeing on this slide is a basic workup that everyone gets. So after this all workup, if we don't find any cause, then we go for some advanced imaging, we go for some advanced workup, and there are some rare causes like a connective tissue disorder, like a cancer, like a hole in the heart, and many, many other causes. And then we chase for those causes also. But this pretty much covers a basic workup for a stroke that everyone comes to the hospital with stroke-like symptoms get. Great.
So Dr. Healy and Dr. Adil, could you discuss some of the medications that patients might be on?
Sure, I can go first. So so in stroke care, there are three things. Number one is primary prevention, then is acute treatment, and then is secondary prevention. Primary prevention means when you have the risk factor, but you never had a stroke, then your cholesterol is high, your blood pressure is high, and based on a lot of scores, we start you on aspirin and lipid loading agent, a lot of medication. That's called a primary prevention. Once you suffered a stroke, you came to the hospital, we give you a TPA, the clot buster medication, or pull that clot, that's acute management. After that, it comes secondary prevention, because once you suffered a stroke, the risk of having another stroke is high. So we wanted to start medication to prevent or to stop having another stroke. So the medications for that is antithrombotic, which includes aspirin, Plavix, and many other medications. So aspirin prevents like about 17 to 18% of stroke decreased risk. Plavix is like around 20. And again, the anticoagulants are bigger guns, and I'll leave the anticoagulation part for Dr. Haley. He will talk about it. And then statins. Cholesterol, high cholesterol is a very common cause of a stroke. We want to keep the cholesterol level, which is LDL, which is called a bad cholesterol in layman terms. We wanted to keep it less than 70. So we start on aspirin, we start on lipid loading agent, which is statins. There's a number of statins. I'm not going to go into the complicated list, the name of the medications. Then, in addition to that, managing a risk factor. If you're hypertensive, blood pressure control is key. If you're diabetic control is important. Healthy diet, and many other things. But in terms of medication, aspirin, Plavix, and your lipid loading agent is the key. And then I'll let Dr. Haley talk about anticoagulants.
Thank you. So one of the reasons that we really want to look for atrial fibrillation, besides the fact that it's very common, is that if we find atrial fibrillation, it significantly changes our secondary prevention for stroke. In other words, it really changes how we approach someone after they've had a stroke. So very commonly, we're going to use antithrombotics or antiplatelet agents in stroke patients, things like aspirin and Plavix, which is also known as clopidogrel. However, if someone has atrial fibrillation, then we know that those agents, aspirin, Plavix, clopidogrel, are not particularly effective in reducing their risk of stroke. And in those patients, if we find atrial fibrillation, we want to use an anticoagulant medication. And these are medications that really were specifically designed to reduce the risk of stroke in the setting of atrial fibrillation. And so that's a time when we're really going to change how we manage this patient and how we're really going to reduce that patient's risk by finding atrial fibrillation and getting someone on the right therapy for it. In prior days, we used Coumadin most often, Coumadin or warfarin as it's known. However, studies have shown that the newer agents like Eliquis and Xarelto are both better at reducing the risk of stroke than Coumadin is, and have a lower risk of complications than Coumadin does.
Okay, we can go to the next slide.
Okay. So throughout your you or your loved one's admissions, you're going to be getting education from the whole entire care team. You're going to be getting educated about your specific risk factors as we are able to ascertain them during your admission, and how to mitigate them, be it a diet, exercise, medications, things like that. We're also going to give you education about your post-discharge care. A big person who's going to be giving your education, and I'm biased in this regard, is your nurse. And so you're going to be getting a lot of information from them. You certainly can ask them questions. If they don't know the answer, they will find them out for you and get the right information for you. So the nurse, your bedside nurse, is your primary point person for education, but certainly the entire team is going to be doing it as well. They're also going to be doing rehabilitation assessments. So you're going to see, now you might think, oh, I can swallow and talk just fine. The speech therapist is going to come and see you just to double check, because difficulty swallowing and aspiration is a definite post-stroke risk. So we want to make sure that you're safe to swallow. So the speech therapist is going to see you, and the physical and occupational therapists are also going to come and evaluate you, and they're going to assess your abilities to complete your activities of daily living, and to do what kind of therapy you might need after you leave the hospital to help get you back to as close to baseline prior to the stroke as possible for functioning. And they'll make recommendations for where they think it's most appropriate for you to go upon discharge. And which leads us to discharge planning. One of the big things in hospitals nowadays is discharge planning starts the minute you come in the door here at the hospital. And it continues throughout your hospital stay, because the picture can change from day to day as to, you know, initially you might have presented with a severe stroke and a lot of disability, but after treatment, you know, 2 days later, you're back to baseline. And we've had lots of instances of that. Or, you know, there have been complications throughout the stay that changed sort of where we think you were going to initially might be able to be discharge wise. And we need to constantly reassess that. So it's a multidisciplinary process. It happens during rounds every day with the whole care team of the intensivist, case manager, social worker, the bedside nurse, the neurologist. They all talk and make determinations with regard to post-discharge caring. The care manager or social worker will be assigned to you, and they will help with assisting with, if it's determined that you need, it would be best for you to go to an acute rehabilitation hospital or subacute rehabilitation, or to go home with home care services and outpatient physical therapy. They'll assess with making those arrangements for you. They can help with home health services. They can also assist with medication, obtaining medication. Certain medications can be very expensive, and our case managers have some ability to help give you assistance with affording your prescriptions. So case managers would definitely play a really important part in your hospital stay as well. And then post-discharge care, I'll turn this back over to Dr. Adil and Dr. Healy for help with this one.
Great. Thank you, Victoria. So post-discharge care, another very important aspect in the stroke care. So as you all might have noticed that it's a multidisciplinary care. From the very beginning, the patient is involved, the caregivers are involved, 911 EMS is involved, then emergency department is involved, and the nurses are involved, and then imaging technicians are involved, and then stroke neurologist, cardiologist, intervention radiologist, physical therapy, occupational therapy, dietitian, so multiple departments work together. Same thing happen after you go home. So step by step, there are 5-6 things that you should keep in mind. Number one, take your medicines religiously. As I mentioned, that once you suffered a stroke, the risk of having a stroke is higher compared to the general population or a person who never had a stroke. So take your aspirin, take your anticoagulation, whether Eliquis or whatever your medication is. That's one thing. Number two, see your primary care. As soon as you discharge, call your primary care, set up an appointment after 2-3 days or a week or two, so that your primary care knows what happened in the hospital, what's going on. Because once you're out of the hospital, it takes little time to connect with the stroke neurologist and other subspecialty. So your primary contact person will be your primary care and can make some changes or meet your requirements. That's the second thing. Third thing, your risk factor control is very important. Your hypertension, your diabetes, your cholesterol, keep an eye on that. Just keep calling, you're talking to your primary care. If your blood pressure is not under control, if your cholesterol is high, if your diabetes are not under control, just keep an eye on that. Risk factor control is very important. Exercise, healthy diet. Diet is a separate chapter, separate topic. We can do a separate webinar on diet. I'm not going to go into that detail. In addition to that, remember the score fast. Again, face, arm, speech, any symptoms, call 911. Time is brain. So these are the important things that you keep in mind. And then again, your therapy, work with your physical therapist at home or a rehab. All these things are very important. And I would say that it's directly proportional. Your involvement, your effort is directly proportional to the outcome. The more you work the physical therapy, the more you're involved in your care, the better the outcome. I'm going to let Dr. Haley and other team to add if I missed anything.
I don't think you really missed anything there, but I would say from a cardiac standpoint, we often want to have patients follow up with us because we want to make sure they're following up on their test results. Do they know what their monitors showed? Do they know what it means? Are there any other steps that we need to take? Is there anything else we should be looking for? If we looked for other causes of stroke, should we be looking for a patent foramen ovale or a small hole in the heart? If we find it, do we need to act on that? If they have a monitor, have we found evidence of atrial fibrillation or not? And then probably even more importantly is looking at patients' blood pressure in the office. Usually I'm going to have my patients monitor their blood pressure at home because getting 10 blood pressure readings at home is worth more than getting one in the office. But I want to make sure that patients are keeping track of that and know what's happening. And that also gives us a chance to review what medications they're on. This is a really confusing thing for people when they leave the hospital. Suburban gives them a nice list. Stop taking this, start taking this, continue taking this. But oftentimes patients still have questions, and it's great to be able to sit down with them and just sort of go over that and try and make things clear.
Okay. So I'm going to leave this up during our question and answer session, but I just wanted to point out to you, these are some really great websites to go to for more information about stroke and stroke treatment, stroke prevention. The National Institute of Neurologic Disorders and Stroke at NIH, which is a collaborator with us here at Suburban on our research. They have some wonderful information and just newly updated. They have some new campaigns, especially related to the relationship between cardiac health and stroke. And the American Stroke Association, stroke.org, also has lots and lots and lots of great information about stroke prevention, also about stroke rehabilitation, sort of what to expect, what are various rehabilitation options. So I definitely urge you to visit those sites for more information. At this point, I want to go ahead and start answering some of the questions that have come in. I'm going to take them a little bit out of order. Anyway. Yeah.
Just give me 1 second before we jump onto the question and answer session. Just for the quick recap from this presentation, I just want to reiterate a few things that symptom recognition, again, take home message, don't forget symptom recognition, very important, call 911. And stroke care has evolved in last 20 years. It was the second most common cause of death. Now it's the 5th most common cause of death. And that's because of all these emergent therapies that wonderful research happened at NIH and other institutions. So call 911, come to the ED on time, and let us help you and reduce the disability. Thank you.
Thanks, Dr. Adil. So as I was saying, I'm going to take the questions a little bit out of order so that we can address some of the questions to answer some specific things that may have come up during the presentation. The first is, does taking a blood thinner such as Xarelto preclude some procedures?
So I can answer that. It does not. Being on a blood thinner will not affect whether or not we will do our part with thrombectomy procedure. In fact, even if the neurologist end up giving TPA, we still do the procedure, so that doesn't increase the risks from our standpoint.
And Dr. Srinivas, this is another question for you. What is the difference between a ruptured brain aneurysm and a hemorrhagic stroke?
So ruptured brain aneurysm is within the subcategory of hemorrhagic stroke. It's a type of bleed. You can bleed into your brain, which is the definition of a hemorrhagic stroke, from a number of causes, one of which is a ruptured aneurysm. So, I mean, they're essentially the same.
And Dr. Dill, can you describe, a question was, what is a wake-up stroke?
Right. So as the term says, wake up. So patients wake up with the stroke symptoms. So any symptoms like facial weakness, vision problem, trouble finding words. When you woke up with symptoms, it's called wake up stroke. Now, why this is different compared to the other is just because we don't know the timing. So if a grandma went to the bed last night at 9 p.m. and woke up 6 a.m. with the symptoms, now what time symptoms start, like a 4 a.m., 3 a.m., we don't know, right? And that's why we say it's a wake-up stroke. And that's why we also categorize these type of strokes in unwitnessed stroke, because we don't know the timing. And here, the MRI comes, as I was mentioning that Suburban is an MRI first institution where we can take these patients to MRI immediately, and we can age the stroke, and we can tell that the symptoms started within 4.5 hour window or not. Does that answer the question?
So if not, please feel free to type back in the question and answer. I can answer this one. Can a person direct the ambulance to Suburban Hospital, and will they listen? I actually posed this question to my contact at Montgomery County EMS, and he said they try to accommodate as best they can when there's a specific request to transport. The only thing that would preclude them from honoring the request is if the patient, if it's deemed by the paramedics that the patient is not stable enough to travel that far. And if that were the case, that they, that the patient was, it would be a risk to them if they took longer than absolutely necessary for transport, that they would take them to the nearest hospital. So you can request, take me to Suburban Hospital, but you have to understand that EMS is going to make the decision based on what they feel is in your absolute best interest, whether it's take you to the nearest hospital or to accommodate your request. Let's see. I heard that Suburban has a stroke center. What is that? Is it a physical office with a stroke team? Dr. Adil?
I can tell. So stroke center basically means that we provide all the care that stroke patients need. And the stroke center basically constitutes of, as I was talking, that it's a multidisciplinary. So, I mean, we definitely have an office that's called stroke center, but really the stroke team is EMS, emergency department, the nursing, the ICU, the PCU, and all these departments who basically work together to take care of the stroke patients. So, I mean, if the question is that stroke center means, is this just an office? Yes and no. Yeah, we have an office which says stroke center, but it's basically a mixture of all the departments that take care of stroke patients.
And we, to that point, we are also accredited by the Joint Commission and Montgomery and the Maryland Institute for Emergency Medical Services System as a certified primary stroke center. So that, especially with the Joint Commission, that is a recognition that we are providing the best care possible and meeting, certain standards of care with relation to stroke. There are only about 17 hospitals in Maryland that are certified primary stroke centers through Joint Commissions and through the Joint Commission. And we were actually just recertified back in September of last year. Okay, this is a big one. We were expecting this one. What is an incidence of having a stroke with COVID-19?
I can take this question. So when this COVID starts, initially, still the literature, the data is all over the place, right? Initially, there was a lot of papers that says that COVID is affecting a young patients and causing a stroke and causing a big clot. But over the period of time in last 1 year, all the data analysis shows that the risk of having a stroke with COVID is not greater than any other disease or any other situation. Because in different studies, it's reported from 0.6 to 2.6%. So really not a very compelling data. Again, we don't know much about this disease. Anything that is happening in COVID patient, we're saying, oh, it's because of stroke, but we don't know, we don't understand. But I'm not seeing a dramatic increase in stroke patients because of COVID.
See, I'm just going to try and paraphrase this question. How can MRI be advocated for when a CT is deemed normal? And what can be said to move the doctor forward to MRI if they're not inclined? So I guess this would maybe be if they didn't come to Suburban and they went for a CT at another hospital just to rule out a stroke. I'll read the whole question. 2 times have witnessed a patient present saying they believed it was a stroke, emergency room did CT scan, and when it came back okay, refused to move forward with MRI. Both time patient or family was right and stroke had occurred. Patient incurred much more damage because stroke treatment was denied for another 24 to 72 hours. How can MRI be advocated for when CT is normal?
Yeah, definitely. I would love to answer because this is my area of interest. So just understand a few things. One is science and one is the resources. So number one, for MRI, it takes a little more time. It needs expertise for a technician to do all these imaging. On top of that, it needs expertise to read. Not everyone can read MRI. This is special training. So there's a lot of challenges. And then in addition to that, previously when like in 1995, the first trial came that's called NINDS, they use CT scan. It's a quick modality. You just look at it. If there's no bleeding, you treat those patients. Now, as I said, in last 20 years, stroke treatment has evolved. Now, wake-up stroke or the patients who present with unwitnessed stroke was an exclusion criteria. If you go to any hospital with the wake-up strokes or unwitnessed, they're not going to treat because they don't have that expertise. Now, this became a standard of care in 2018, just recently. So I think because of this publication, because of this clinical trial, I think this provides an opportunity to advocate in favor of MRI. Because as I said, according in literature, 25 to 30% of patients that presents to ED present with unwitnessed onset or a wake-up stroke. So that's the one point. We have a literature, we have a evidence, we have a clinical practice guidelines, and we can advocate for that. The other thing is, as very well said in the question, that the CT was negative and then MRI came positive, or if the symptoms were very mild. So again, for patients with a very mild symptoms, MRI can be beneficial, of course, because even if it's a very small stroke, within 5-10 minutes, MRI can pick. So we're trying to advocate becoming an MRI first. There's a couple of hospitals in DC. They're now MRI first, and I think there's a lot of challenges. There is a lot of resource problem. MRI first needs a lot of, it's a cost thing and the resources, reading an MRI, as I said. So, but I mean, Suburban is a big advocate for MRI.
Are there any differences in the symptoms between a stroke, an ischemic stroke versus a hemorrhagic stroke?
So I would say no. As I was mentioning in the symptoms, the headache can, patient presents with a headache can have a ischemic stroke and can have a hemorrhagic stroke. And if you have a bleeding in the language area, it's going to give you the same language problem, difficult word finding difficulty or difficulty in understanding. There are some symptoms you can tell, like if it is a bad headache, like the worst headache of the life, that is likely hemorrhagic stroke. That's not ischemic stroke. But I would say that based on symptoms, we cannot differentiate whether this is ischemic stroke or hemorrhagic stroke. And that's why imaging is key and vital to get the imaging as soon as possible so that we differentiate these two types of stroke and the treatment is different.
Dr. Srinivas, can you follow up a little bit about the hemorrhagic, the aneurysms, the treatment, if it's just found that the hemorrhage is due to an aneurysm rupture or that there is an aneurysm discovered? Can you talk about what the treatment is for that?
Yeah, absolutely. So like Dr. Adil said, the symptoms, there's a lot of overlap between the two, and sometimes we tell the difference without imaging, but the treatment between the two types of strokes is very different. And in the case of a hemorrhagic stroke, particularly from an aneurysm rupture, there are a couple of things that need to happen. Here at Suburban, besides imaging either through CT or MR or CT angiogram or actual catheter angiogram by us here in interventional radiology to establish that the actual source is from an aneurysm, the next step in managing that would usually be a neurosurgery involvement. And depending on if it was indeed an aneurysm or what type of bleed into the brain that it was, most likely would be transferred to Johns Hopkins in Baltimore, where there is a whole expert team specifically dedicated to aneurysms particularly and dealing with a hemorrhagic stroke overall. And so we do have that nice connection here at Suburban with Hopkins as a Hopkins staff and faculty, myself, that we have that communication and we're closely involved with them there in those kind of cases.
Dr. Adil, can you talk about, it says, how is a hemorrhagic stroke treated in the hospital? Are there any medications which can stop or reverse the effects of the bleeding? So we'll say it's not due to an aneurysm, it's due to, like chronic high blood pressure or something like that.
Right. So for hemorrhagic stroke, definitely important is what is the etiology. That is the specific treatment. But there is some general treatment that every patient should get. And the most important is blood pressure control. We want to keep the blood pressure on the lower side so that the bleeding, to decrease the bleeding. So whenever there's a bleeding, it has a tendency to expand. So we wanted to decrease all the factors or all the factors or the risk factors so that the hematoma or the bleed should not increase in size. So one of the important things is keeping the blood pressure lower, like less than 160 or less than 140. That's the one thing. If this bleeding is because of TPA, for example, we give the clot buster medication for ischemic stroke, that medication can cause a bleeding in the brain. Then we have a different reversal agent and we reverse that bleeding. We give like FFP, we give platelets, we give vitamin K. That is another. If it is because of aneurysm, mostly it's the intervention you do as Dr. Srinivas was talking about. So there are general measures, blood pressure control, and then there are specific treatments specific to the cause.
I'm going to throw this question to Dr. Healy and Dr. Adil because I know this can become an issue with heart issues. Do patients with connective tissue disease have a higher propensity for stroke than the general population?
Yes, I would say. So again, this is the area, as I was saying, that when we were talking about the workup of stroke, there was a lot of investigations, the basic investigations. And I was mentioning that when all those investigations are normal and you don't find any cause of stroke, then you look for rare cause. So connective tissue disorder is one of the rare disorder that can cause stroke. Now, again, the literature is very, very little. We don't have a big studies because it's not very common. But yes, I have seen patients with connective tissue disorder suffered a stroke, with both hemorrhagic and both ischemic.
Yeah, I mean, I think that's a great question. And just as those disorders can cause cardiovascular issues in the great vessels coming off the heart, in specifically the aortic dissection is a significant risk in those patients. I think it's also true of stroke.
Can a person have a minor stroke and not be aware of it?
Yeah, excellent question. Great question. Because again, the MRI first and minor stroke is the special areas that Suburban is interested in. So our research team at NIH, and I'm the part of the NIH also, we're very much interested in minor stroke. So sometimes you have a subtle headache, sometimes you have a little bit dizziness and symptoms resolve, a little bit of a numbness. So what we do whenever a stroke patient comes to the ED, we give them a score. That's called National Institute of Health Stroke Severity Scale. And that's start from 1 and goes up to 42. The higher the number, the bigger the stroke, or the stroke. So it's mild, moderate, and severe. So what we do is like we give numbers to all of these sign and symptoms. And if the number is less than 5, like just a little bit of trouble finding word, just a little bit of a numbness, or just a confusion. If it is less than 5, it's categorized as a minor stroke. So yes, a lot of times patient presents with a very subtle symptoms or sometimes quick symptoms and resolve, and we take them to the MRI and we saw a stroke.
What is the relationship between NIH and Suburban regarding strokes?
Another great question. So we have a great collaboration with the NIH, and we're doing a lot of studies. So all patients that presents to Suburban Hospital, we approach them, we screen them, and then ask them if they are interested in participating in stroke research. Like I was talking about the minor stroke and the large vessel occlusion. And then we enroll these patients in the NIH study. And then we do a number of MRIs, look at the outcome, and then we have published so many papers.
Dr. Gilly, can you talk about more of the heart healthy diet? Because that's what we tend to tell stroke patients is, be on a heart healthy diet. Can you describe that in more detail?
Sure. Well, I mean, I think the centerpiece to any heart or cardiovascular healthy diet is going to be lower sodium. We know that our diets often include 3 to 4 grams a day of sodium, which is about twice what is healthy from a cardiovascular standpoint. So I think that's going to be at the top of the list. Other things that are going to be important is limiting saturated fats. Is going to be very important. Probably more important than the cholesterol in the food is the amount of saturated fats. And then additionally, it's not only a question of not eating certain things or not taking in certain things, but making sure that you're getting enough of the things that are healthy. And so I think we're really going to emphasize trying to include fruits and vegetables in every meal. Is a key part because that will also tend to decrease your intake of other things and making sure that you're getting enough fiber in your diet. And I think those are really, for me, the keystones of a cardiovascular healthy diet.
Let's see. So a follow-up question, can more potassium counteract sodium? My diet has maybe twice as much potassium as sodium.
So that's a tough one. Counteract, I'm not sure, might be too strong a word, but certainly diets that are richer in potassium as opposed to sodium are going to be more healthy from a cardiovascular standpoint than diets that are higher in sodium. So you're going to get more potassium from fruits and vegetables. You're going to get more sodium from anything that is processed. Another way that I like to put it is when you look at your food, the easier to tell what it once was, the healthier it is for you. And so, you know, I think that I don't know if you can really substitute one for the other. That's a little tough, but you're looking for a more potassium-rich and less sodium-rich diet.
So I like this question. Does your multidisciplinary team include the emotional side of stroke, particularly those with aphasia and cannot communicate as well in recovery? By the way, Suburban's neuro team saved my friend's life. Thank you. You're wonderful. I think it's very important to recognize, and when I meet with stroke patients here, to stress that depression is a very common, very commonly experienced by patients after they experience a stroke, both from a psychological perspective. This person might have been cruising along in life and all of a sudden, bam, they've been diagnosed with a stroke, and that can be really life-changing. And also just physiologically, your brain has taken a hit, and it takes time for things to get rewired and to kind of come back online. I describe it a lot of times to patients as a computer rebooting, and it needs time to come back, to bring back everything. And so I try to stress to patients to be cognizant of that, to tell their loved ones to be on the lookout for that as well. And obviously having difficulty communicating can certainly contribute to that. That's one of the reasons why we definitely bring in speech therapy to consult and to help patients with strategies. Unfortunately, you know, here at the hospital, we're really dealing with the acute stage of the process. And so a lot of the really hard work and the rehabilitation occurs after the patient's been discharged. But certainly we try to implement, in consultation with a speech therapist, strategies to help the patient communicate while they're here in the hospital with us, so that we don't add to their level of frustration, and that we can make sure that they you know, are able to get their needs across, and we can make sure that they are understanding everything that's going on and about their treatment plan. I hope that answers your question a bit. If it doesn't, please feel free to type more in the chat box. I don't know if any of the physicians have anything to add to that. Let's see. Dr. Dill, I hope you're on. I know you're having some computer issues. Question is, what is a TIA? Awesome question.
Yeah, can you hear me? Yeah, my computer decided to restart. But can you hear me properly here?
Yes.
Good. So TIA is a transient ischemic attack. So the actual definition of TIA is when you have a neurological symptoms and that resolves within 24 hours, that's called TIA. Now, this can be because of a blood supply issue, which is a stroke. This could be because of any other reason. But if you define that event that it's because of the decrease in the blood flow in the brain, and it's a minor symptoms, and this resolve within 24 hours, and when you do imaging, you don't see anything, that's TIA. Now, TIA is one of the risk factors. The people who suffer TIA is on a higher risk of having a stroke. The risk is higher in first 10 days, and the risk decreases by 30 day, 1 year, and 5 year. So TIA is a lot of people say mini stroke, which I agree, it's a mini stroke. You don't see a lot of things on the imaging, but it's an event that's because of the narrowing of the blood vessels in the brain, and it's a blood flow problem. So that's the TIA.
I've had a stroke recently, at least 3 at the same time, actually, that split to different sides and areas of my brain. And I still have symptoms of numbness on the left side of my body and the right side of my face. It's been over 3 weeks. Could you explain more about numbness symptoms and how long they typically remain? And actually, maybe if you could also sort of cover kind of what is the expected time frame for optimal stroke recovery?
Victoria, do you mind repeating question quickly?
Oh, sure. I had a stroke recently at least three at the same time, actually, that split to different sides and area of my brain. And I still have symptoms of numbness on the left side of my body and the right side of my face. It's been over 3 weeks. Could you explain more about numbness symptoms and how long they typically remain?
Great question. Great question. So yes, numbness is one of the common symptom of stroke. And usually when someone suffered a stroke in the thalamic area, thalamus is the area in the brain that connects the upper part of the brain and the lower part of the brain. And it has a lot of sensory connections, right? There's a lot of electrical activity going on there. So when you suffered a stroke in that area called thalamus, it gives you a lot of sensory symptoms and numbness. Now, in terms of timeline, it depends how big the stroke is and what is the mechanism. Now, in clinical trials, they looked at the outcome. They assessed the outcome at 3 months. So wherever you will be at 3 months, that will be your new normal. So that doesn't mean that there will be no improvement after 3 months. There will be an improvement, but we don't understand well because we have not studied that. There are a few studies that looked at the symptoms improvement at 1 year. Definitely it continued to improve after 3 months. So I think if you have these numbness symptoms for last 3 weeks, I would give a few more weeks until 3 months. I'm hoping that it will improve. But if it doesn't improve, then there are certain medications that we can start to decrease the numbness and control.
Are periodic painless throbbing sensations in the side of the head symptomatic or problems that should be checked regarding strokes or something else?
As I said, the headache is a very non-specific symptom for stroke. Usually, if you're having a bad headache, as I said, that worst headache of my life, then definitely you should check. If you're a headache or migraine person, but this headache is different than that, you should definitely, it's a red flag, you should check. It's hard to tell throbbing. I mean, I have seen a patient with a very subtle no throbbing headache, but I found a very small stroke in the back of the brain. I would say that if you have a risk factors, if you have hypertension, if you have diabetes, if you have a high cholesterol, and all these risk factors, then I think I would say that you should definitely get an imaging and rule out if this is a stroke or not.
How common is it to develop trigeminal neuralgia following a stroke, and how to tell the difference between the symptoms?
Not that common. Not that common, but I have seen few patients. But again, as I said, people can mix trigeminal neuralgia with the thalamic stroke. So trigeminal neuralgia is the problem of the nerve, right? That's the problem of the nerve. The thalamic stroke is the part of the brain that is giving you a numbness. So two different pathologies with the same symptoms, right? I have very rare couple of cases I have read causing a trigeminal neuralgia after a stroke. Usually it's the stroke itself causing that numbness, and it's not a trigeminal neuralgia. But the treatment is same. I mean, the medicine that helps for trigeminal neuralgia helps for the numbness causing by stroke.
Can a patient who had a stroke in 2019 and was treated at Suburban be included in an NIH study, or is it too late for that?
2019 or too late. Short answer is too late.
Okay. My mother has Parkinson's disease and was treated for that. However, when she visited me and her speech was getting worse, so I took her to my friend who is a neurologist, and he ordered an MRI and showed she had a lacunar stroke. So how would you differentiate some of the symptoms of a stroke versus Parkinson's disease?
Again, it's very hard. So Parkinson is a very, very interesting disorder. Usually the Parkinson patients are otherwise very healthy. The risk of stroke in Parkinson is very low. I have seen very few patients suffering a stroke with Parkinson. So that's the one thing that is very, very well published in the literature. Now, Parkinson causes slowing and trouble talking. So again, as I said, when I was talking about symptoms, like these, a lot of symptoms are non-specific. You can have a trouble finding words with a migraine. You can have this numbness because of any other nerve problem. You can have a dizziness because of a migraine. You can have a dizziness because of ear problems. So the symptoms are very, very non-specific. Really differentiating between the symptoms of Parkinson's stroke, not possible. There's a one thing, if the Parkinson's symptoms develop a new symptom that is sudden in onset, like immediately, that's a red flag. So any Parkinson's symptoms, any new neurological symptoms, sudden, or any previous symptom worsening should get MRI or CT to evaluate for stroke.
Okay. When in doubt, get it ruled out, right?
Yeah, well,
Okay. We had a question that was actually submitted online a couple of days ago, and Dr. Healy, maybe you can answer this. It's, are there any special considerations for patients with heart failure?
Well, a lot of the risk factors for heart failure are the same as risk factors for stroke. So, and number one on that list is hypertension, right? Control of hypertension has been shown to decrease people's risk for both stroke and heart failure. So I think that would be number one on my list. I think number two would be that people who have heart failure are more likely to develop atrial fibrillation, which is a significant risk factor for stroke, as we've discussed. And I think number three would be some people who have heart failure and have a weakened heart muscle or cardiomyopathy can also develop clots that are specific to those patients. And those are things that when we look at people's hearts with echocardiograms, we look for, and we may choose to treat that if we find it. So I think those are really the things that I would consider, but I think number one on that list would be, not surprisingly, hypertension.
Okay, we don't actually have any
Victoria?
more, oh, wait, yep.
Yeah, so I saw there's a question in the chat box about diet, right? And there was some concern that why someone said that we can have a separate webinar of diet. I mean, the reason why I said that it's a huge topic and we wanted to cover everything. But regarding diet, Mediterranean diet is recommended diet for stroke patients. And it's a very dynamic process because sodium needs to be managed, the protein needs to be managed, and then at the same time, you suffered a stroke and a lot of risk factors. So the diet management, maybe one thing is good for a stroke, but at the same time, it's affecting your hypertension and diabetes, right? So that's why at Suburban, you get a separate consult from a dietitian to get like very customized diet plan, which is compatible with your risk factors and stroke. But in general, American Heart Association recommends Mediterranean diet, which is best for stroke prevention.
Okay. We don't have any other questions at this point. Just want to give everyone some last minute thoughts. We have a question. They don't think it was directly from the vaccine, but I developed a dissection in my vertebral artery, probably from the stress and headaches caused by the vaccine. Is there a way to see if these are being looked at? Is there any research that any of you are aware of?
What is the question?
Vertebral artery dissection caused by the COVID vaccine.
Oh, COVID. No, so I looked at the literature. Actually, I presented in a neuroscience symposium the neurological problems in COVID vaccine. I would say that there is definitely COVID is making the blood more thicker, and the clotting. The clotting thing is more often happening in COVID patient, and when there is a more clotting, the risk of forming a clot in the brain is high. That just kind of a underlying principle, right? But specifically vertebral artery dissection, I haven't looked at in the literature and didn't go through my eyes.
And on a related, is a person who has had a stroke, is there a potential concern with taking the COVID vaccine?
No, there is no exclusion or no contraindication. If you suffered a stroke, you should not be getting vaccine. No, not that I'm aware of. I have seen a couple of patients, they suffered a stroke and then they took a vaccine after a few months, did it fine.
I think I just want to add to that. One of the most frequent questions we've been getting recently is, I have heart disease. Is it safe for me to get the vaccine? And the answer is yes. Not only is it safe, but you should get it. And I'm going to do my due diligence here and just say that to everybody who's on this. The COVID vaccines are extremely safe, very effective, and the exclusions of them are extremely rare.
COVID is far worse when you have heart disease than the COVID vaccine. Okay. Dr. Srinivas, do you have anything to add?
No, I can just piggyback on that. Get the COVID vaccine if you can. And like Adil said, with the increased risk of clotting with COVID, if you have risk factors for stroke, even more reason to hurry and get that vaccine.
All right. I don't see any other questions at this point. I'll just leave it open for a couple more minutes. Any last words of advice, gentlemen?
Early recognition, call 911, let us help you.
Be fast.
Be fast.
And don't drive.
I just wanted to thank you all for your sharing your expertise with us today. I always learn so much through these webinars. So thank you so much to each and every one of you. I just want to remind our participants that I will be sending out the recording in a couple of days. It'll be made available on Suburban's YouTube page. So that is one thing. And just thank you very much for your time. And if it's okay, I'm also going to send out the slides as well. That's okay with you, Victoria?
Yep.
Okay. So I'll send that out as well. So thank you very much, everyone. I think there is one more question.
Does Suburban allow walk-ins for the COVID vaccine? Not at this time. In fact, we are actually in the process of winding down our COVID vaccination clinic because there are so many other clinics available in the general public. But you know, it was wonderful I participated in that vaccination clinic. It was wonderful seeing everybody there, and we were so happy to be doing it. And we thank our community for all the support you've given us over the last year and a half as we've been dealing with COVID. It's been beyond rewarding for all of us here at Suburban.
Thank you. So thank you, everyone. It's been a wonderful hour and 17 minutes. Thank you again, and I hope you have a wonderful rest of your day. And I think our takeaway message is, if you have experienced a stroke, go to the hospital and also get your COVID vaccine as well. So thank you again. Have a wonderful afternoon and see you next time. Bye.
Thanks, Eleni.